What we were doing today really was describing the results from a 5-year study, the Canadian Prostate Cancer Genome Network, which was used to really try to triage patients into aggressive and non-aggressive groups for potential intensification of therapy, some novel trials. And so what we did actually was look at the inherent genetics of these patients using whole genome sequencing, and really found that there are specific groups of patients in which their clinical parameters are exactly the same and yet have defined genetic profiles that show they have aggressive disease, and that they will fail surgery or radiotherapy within 18 months of that therapy. Those patients probably have occult metastases, and they need better therapy than we're currently giving them. They need better adjuvant therapies. And so designing a test now based on this kind of discovery approach for whole genome sequencing allows us to pull patients apart and start this type of intensification trial. So patient groups apart, certainly patients within groups. So right now, 100 patients will come through the door. They'll have similar Gleason scores, they'll have similar PSA tests, and similar staging investigations, and they'll be non-metastatic. And yet we know anywhere from 30 to 40% of those patients will fail local therapy. But we can't tell them up front, a priori, who they are. That's really the basis of the Canadian study, was to try to do that, to pull the 30 or 40 patients out of the rest of the group and say that those are the patients now we really have to put a microscope on and actually get them into novel trials, because a local therapy alone is not doing them justice. And even within the 30 to 40% they're failing, there's a further group that fail quite quickly. And we actually think those are the patients most at risk for metastatic disease and developing castrate resistance. So actually acting earlier with those patients can prevent the onset of metastatic disease, prevent the onset of castrate resistance, and therefore change the cure kind of numerator to denominator in this group of patients. That's a really good question. So our imaging is getting better and better in terms of looking at patients that might have metastases. So we used to use traditional bone scans, for example, to define whether or not there are widespread metastases. But now we have PET scans, particularly PSMA, that might be much more sensitive for that. So in concert really with the genetic test, the new trials going forward have to have best imaging as part of that triaging kind of equation. So we're not there yet. That's for the next prospective trials. It's to prospectively validate the genetic test, but in the era of best imaging, which now really would include a PSMA scan. Yeah, well, so these trials are just about to be started, and there are a number of individual trials worldwide. I think what I was saying is that these trials now are going to be based on more, I would say, multimodal indices. So patients that not only have genetic instability, for example, but might also have hypoxia. So more complex signatures up front, and then to actually look at those agents, for example, that might hit both hypoxia and genetic instability, such as a PARP inhibitor or an anti-hypoxia approach. So the similarity is the idea of a biomarker-driven set of trials in an otherwise localized disease where you're trying to really find best adjuvant therapy. I suppose a slight difference here would be that the types of signatures that we are developing are really ones of complex phenotypes and complex tumor types. And so the actual signatures might be more complex. Yeah, absolutely. I think that we can't not use abiraterone now based on the data. So primary chemotherapy and abiraterone are probably drugs that definitely will be used in this high-risk setting. And then the question, though, is that are there specific tumor types in which you wouldn't use abiraterone? Because, of course, you can get resistance to that drug. And there was also another trial that was at ASCO comparing the first use of enzalutamide and then a crossover to abiraterone failure, or starting with abiraterone crossover. And actually, there's no difference between the two arms, suggesting that, again, the sequencing of the drugs and who's going to benefit starting one or the other, we really don't know. So I would say that, that the approach to very high-risk disease, where we believe that the occult metastatic burden is high, would include chemotherapy and or abiraterone. And the question is, can we target it a little bit further based on the biology?